Pleasant day, everyone. We are the group number 2, and we will discuss our topic 2 entitled Bipolar Disorder.
Bipolar disorder. It is a maniac depressive disease, often known as maniac depressive illness. It is a brain ailment that produces unexpected swings in mood, energy, activity levels, and capacity to carry out daily duties. So, kapag yung silingtang bipolar, ibig sabihin dalawa na siya emotions ngayon na experience mo, either maniac siya or hypomaniac. When we say maniac, gabi na siya ka-hyper, sa sobrang ka-hyper daw pwede ka na nakasulat sang isa ka libro. Tapos sobrahan ka bala ka productive to the point na daw tanan maobra mo sa isa ka adlaw. Tapos kapag hypomaniac naman, opposite na siya sang maniac. Ari naman sa sobrahan mo ka down, hindi mo na siya mapagawas.
Epidemiology. In the US, there has been an increase in bipolar diagnosis among adults by up to 50% and a more than quadrupling in children. About 46 million people around the world, including 2.8% of the US population, have bipolar disorder. So according to the given picture, there are 40 million people in the world that are affected by bipolar disorder, and 2% people are affected by bipolar disorder at any point of the time during a year. There are 2.9% of adolescents suffer from bipolar disorder, and women are the more likely to suffer from bipolar disorder too, and bipolar disorder is the highest percentage of severe impairment among all mood disorders.
Pathophysiology of bipolar disorder. So, an altered connectivity within key region of the brain has been thought to play a significant role in the disorder. And when we say functional connectivity, it characterizes how brain region works together in generating thoughts, emotion, and behavior. So, an increased connectivity within specific brain regions involved in emotional control, such as amygdala in ventrolateral prefrontal cortex has been reported, while reduced connectivity in volume is found in regions linked to cognitive control such as dorsomedial prefrontal cortex. And specific alteration in these brain regions underlie both manic and depressive moods. So, many researchers suspect that the mood changes and cognitive changes seen in bipolar disorder are caused by alteration lang ng synaptic functioning rather than dysfunction of individual neurotransmitter.
Etiology for bipolar disorder. Scientists are learning about the possible causes of bipolar disorder. So experts believe that bipolar disorder is partly caused by an underlying problem with the balance of brain chemicals called neurotransmitters. So for genetics, bipolar disorder tends to run in families. Children with a parent or sibling who has a bipolar disorder are 4 to 6 times more likely to develop the illness compared with the children who do not have a family history of bipolar disorder. Studies of identical twins have shown that the twin of a person with bipolar illness does not always develop the disorder. The study results suggest factors besides genes are also at work. It is likely that many different genes and persons' environments are involved. So, bipolar disorder is frequently inherited. Bipolar disorder is most likely psychiatric disorder to be passed down from family.
We will now proceed to the clinical presentation of the bipolar disorder. So we have actually two different episodes of the bipolar disorder. The first one is the manic episodes and the other one is the depression episodes. However, we will mainly focus first on the manic episodes. So the term manic episode actually describe a state of a human being that is characterized by either high energy, excitement, and euphoria over a sustained period of time. So this is an extreme change in mood and cognition that can interfere with either the school, work, or either sa home life ng isang tao. So the following are the clinical presentations. The first one is the feeling overly happy for a long period of time. The second one is talking very fast with racing thoughts or quickly changing ideas or topics kapag nakikipag-usap. The third one is the becoming easily distracted. Fourth is having overconfidence in abilities. And last is engaging in risky behavior as the gambling or either reckless driving and pati na rin ang paggagastos ng money. All in all, these behaviors must represent a change from the person's usual behavior and be clear to friends and most importantly to the family of the patient because symptoms of the manic episode are commonly require a person to receive hospital care agad to stay safe. The last episode for the bipolar disorder is the depression episode. This is where a period is characterized by a low mood and other depression symptoms that last for about 2 weeks or more. So when experiencing a depressive episode, a person can try to make changes to their thoughts and behaviors to help improve their mood. So symptoms of the depressive episode can persist for about several weeks or months at a time. Less commonly, depressive episodes last for over a year. So the following are the clinical presentations for the depression episodes. The first one is feeling sad or hopeless for a long period of time. Second is significant change in appetite. So in here, may possibilities na kunwari, so this day, may gana kang kumain and for the next day is wala ka nang ganang kumain or hindi ka kumakain at all. The third one is thinking about or attempting suicide. So specifically kapag ikaw lang mag-isa, there are times na makaiisip ng isang patient na he or she wants to end her life already by attempting a suicide. The fourth one is feeling fatigue or lack of energy. Dito naman is, kunwari, kagigising mo lang, pero wala pa nag-start ang day is pagod ka na agad. And last one is problems with memory and concentration. So, in here, may mga like the short-term memory loss and nahihirapan mag-concentrate or mag-proceed sa isang situation or bagay kasi madaling ma-distract from a certain things.
So next is for non-pharmacological treatment. So first, we have interpersonal, family, and group therapy. So it is a form of psychotherapy that focuses on relieving symptoms by improving interpersonal functioning because it really can help if may nakakausap yung mga may bipolar disorder because in bipolar disorder, there are times na they are overly happy and energized and there are times na feeling very sad or hopeless naman sila. So, in between those periods, they usually feel normal. Next, we have cognitive behavioral therapy. So, it is a type of psychotherapy that can be used to help manage bipolar disorder. So, when we say psychotherapy, it may involve a one-on-one interaction with the therapist, and it may also involve group sessions that include the therapist and other people with similar issues. Next, we have electroconvulsive therapy or ECT. So it is based on the idea that your feelings, thoughts, and behaviors are all connected. So it can help lessens the frequency of the bipolar mood swings in bipolar disorder. And lastly, we have psychoeducation. So psychoeducation treatment involves providing patient with information about bipolar disorder and its treatment. So with a primary goal being to improve adherence to pharmacological treatment by helping patients understand the biological roots of the disorder and the rationale for pharmacological treatments.
Pharmacologic treatment for bipolar disorder. So, as you can see in this slide, there is the left part. It tells us that there is a brain imaging laboratory for bipolar disorder. As you can observe, merong Ang in-examine dito is yung thickness ng gray matter. Ayan, thickness ng gray matter. However, even though na meron ganito, it is still not an accurate method for diagnosis, and it does not assist in selection of medication for bipolar disorder. So, need pa rin ng accurate and thorough mental assessment, interview to the patient. So, this may be done with a psychotherapist, psychometrician, or psychiatrist. Because the clinical presentations of bipolar disorder varied individually. So, ang treatment must be individualized also. And ang main concern dito sa bipolar disorder, or ang main goal, is to achieve stabilization. So, the treatment varies of what episode or ano ang mas needed na i-mitigate sa patients in order na ma-achieve yung stabilization na hinahangad natin. So on this right side, nakaangkop pa rin dito yung patient-centered care, which is collect yung data, assess kung ano nga yung klase ng bipolar disorder meron yung patient, thorough planning, then implement, follow up, monitor, and evaluate. So now, let's go on to the pharmacological treatment of bipolar disorder. So we have here a general guidelines. So in general, then medications can be added and tapered as long as na-achieve na dahan-dahan ng patient yung stabilization na gusto nating mangyari. So dapat ang patient and the family members must be educated about this disorder and the treatment. Dapat informed sila na long-term adherence to the treatment is very important in here. Kasi ang maintenance for bipolar disorder is for lifetime. So, yun yung nga yung sinasabi ko kanina na mood stabilizer. Yun yung i-maintain nila habang buhay pa sila, ganun. So, in here we have the general guidelines for acute manic or mixed episode. We actually have 4 acute manic or mixed episode, hypomania, mania, and acute depressive episode. 6D mild to moderate depressive and severe depressive. So first, dito sa acute manic or mixed episode. So, general guidelines, first assess for the secondary causes of mania or mixed states. Kasi baka dahil lang siya sa alcohol or drug use. Second is to taper off antidepressants, stimulants, and caffeine if possible. Then, third is to treat the substance abuse if ever na meron nga na secondary causes siya ng episodic. Next is encourage good nutrition. So, along with pharmacological treatment is still proper diet, regular protein, essential fatty acid intake, may exercise, adequate sleep, stress reduction, and psychosocial therapy. Next we have here is to optimize the dose of mood stabilizing medications before adding benzodiazepines. If psychotic features are present, add antipsychotic. Then ECT, or what we call electroconvulsive therapy, is used for severe or treatment-resistant manic mixed episode or psychotic features. ECT is actually the last line na ng treatment kasi for severe na siya na conditions. So, done siya under general anesthesia. May small electric currents lang or probes na ginapass through sa brain para ma-trigger ang brief seizure lang. So, ang ECT na kasi ito is mag-cause siya ng changes in brain chemistry na maka-reverse ng symptoms of mental health conditions, specifically bipolar disorder. And lastly, valproate is a preferred medicine for mixed episodes and rapid cycling. For hypomania here, we have a first optimize the mood stabilizer like lithium, valproate, or carbamazepine. So, consider adding benzodiazepine for short-term adjunctive treatment of agitation or insomnia if needed. So, yun yung sabi dito sa manic na i-optimize mo na yung mood stabilizer na maintenance before adding benzodiazepines. Mag-add lang if gina-insomnia na or may agitation ng patient. Alternative medication treatment is carbamazepine if it does not tolerate the atypical antipsychotics or oscarbazepine. Second, we have here is the, if inadequate pa rin, consider drug combinations like lithium plus anticonvulsant or an atypical antipsychotic. Example ng anticonvulsant, carbamazepine and mga benzodiazepines. For atypical antipsychotic, yung tatlo, olanzapine, quetiapine, risperidone. So, last naman, if ever na, another combination drug is anticonvulsant plus anticonvulsant or anticonvulsant plus atypical antipsychotic. For mania naman, the first two drug combinations must be lithium or valproate plus a benzodiazepine or anticonvulsant. It is for short-term adjunctive treatment of agitation or insomnia, same pa rin. Then, lorazepam is recommended for catatonia. Catatonia yung state of immobility or yung lack of movement. Yung parang ang patient is natutulala lang. Tapos, wala siyang awareness about the surroundings. So, yun yung parang matutulala lang siya. Tapos, hindi siya masyadong makagalaw. Nagiginaw. Basta hindi siya masyadong makagalaw dito sa catatonia. So, next is alternative medicine would be carbamazepine again. Or kung hindi naman matolerate is oxacarbazepine. So, medyo same lang sila, no? May recommended lang talaga sa mania na lorazepam for catatonia. Then, second, if response is inadequate, consider naman ang 3 drug combination. We have lithium plus anticonvulsant plus atypical antipsychotic or anticonvulsant plus atypical antipsychotic. So, ang third option, if hindi pa rin talaga adequate, consider against the ECT or the electroconvulsive therapy. For mania with psychosis or catatonia, add clozapine for treatment refractory illness. So, next is for acute depressive episode. So, again, assess for secondary causes of depression. Next is taper off the antidepressants, stimulants, and caffeine. Next is treat substance abuse and same pa rin na encourage nutrient, optimize mood stabilization, then ECT for severe. Ang ano lang dito, pinagkaiba is lithium and or lamotrigine is more preferred than valproate for bipolar depression. For mild to moderate depressive episode, we have here the initiate or optimize, again, the mood stabilizers such as lithium or lamotrigine or alternative for anticonvulsants, valproate, carbamazepine, or oxacarbazepine. For severe, we have here, mag-start ka na agad sa 2 to 3 drug combinations. Lithium or lamotrigine plus antidepressant. Lithium plus lamotrigine. And if there is psychosis, a typical antipsychotic. Alternative naman, valproate, carbamazepine, and oxcarbazepine. So, if the response is inadequate, consider adding naman another atypical antipsychotic, quetiapine. And if inadequate naman again, consider 3 drug combinations. And fourth, if the response is adequate, consider ECT. So, ECT talaga or elective convulsive therapy ang last line of treatment kapag inadequate ang lahat ng pharmacologic medications. So, here are examples for pharmacologic treatment. We have here carbamazepine 2 milligrams along with dose, formulation, and proposed mechanism of action. So, ito to carbamazepine, mga brand name niya, Tegetrol, Epitrol. So, 2 milligrams ang available. This is divided into 2 or 4 doses. Then, adjustment is needed for hepatic impairment. So, use alone. And meron siyang extended tablets na should not be swallowed whole and also not broken down. And meron ditong carbatrol, may special drug na carbatrol which is ginasprinkle lang siya sa food. So we have here again oxcarbazepine, yung alternative niya, 3 mg twice a day. Use if patients have failed treatment with carbamazepine and intolerable side effects. And mas fewer ang side effects niya. Typical antipsychotics kanina yung mga ariprazole, arsenapine, cariprazine, lurasidone, and olanzapine. Next, meron again olanzapine and may combination, Symbyax. Quetiapine or Seroquel, divided in once or 2 daily when stabilized. Then benzodiazepine here we have used in combination with other medication kanina, diba? Plus anticonvulsants, ganyan. So for benzodiazepine is only for short-term adjunctive sedative hypnotic agent.
So next is for the prevention. There is no sure way to prevent bipolar disorder. However, treatment at early signs of psychiatric disorder can help prevent bipolar disorder. So first strategy to prevent bipolar disorder is to pay attention to warning signs. So addressing early symptoms can prevent episodes from getting worse, and you may have identified a pattern to your bipolar episodes and what triggers them. So you need to pay attention to early warning signs. So you can call your doctor if you feel you're falling into an episode of depression or mania, and involve family members or friends in watching for those warning signs. Second is to avoid drugs and alcohol. So using alcohol or recreational drugs can worsen your symptoms and make them more likely to come back. So you need to avoid drugs and alcohol because they can also lead to drugs being less effective and can further worsen the symptoms. Next is to take your medications exactly as directed. So you may be tempted to stop treatment but don't stop your medications, because stopping your medication or reducing your dose on your own may cause withdrawal effects or your symptoms may worsen or return. So you must continue to intake your proper medications that your doctor prescribed in order to see the improvements in yourself. And foods to avoid. First, these are caffeine, sugar, salt, and fat. First, you need to avoid caffeine. Caffeine is an underappreciated bipolar trigger and can also impair sleep. So according to Jess G. Federowicz, an associate professor in the Department of Psychiatry and Internal Medicine. Second, to avoid is sugar, because sugar makes some bipolar disorder drug treatments less effective.
Third is salt. So if you're taking lithium for your bipolar disorder, you need to carefully monitor your salt intake because they can increase the risk of lithium toxicity. And also fat. So you might have heard that the fat in foods could alter the way your body uses medications. So eating these unhealthy foods or these foods need to be avoided when you have bipolar disorder because they can lead to a host of ailments. But a lesser known effect of poor diet, and it can contribute also to bipolar mode episodes. And while there is no specific diet recommended for bipolar disorders, and certain food choices may help manage manic episodes.